Why is it that there are patients who do intermittent fasting, they don't have success? Why are there people that try doing nutritional ketosis and they don't have success? The question is, why are some of these things failing for people instead of saying they're not doing it right? And there might be a potential of that. But let's give them the benefit of the doubt that they actually are doing it right. But there's something that's getting in the way. And that something could be intrinsic, genetic, or it could be something exogenous that becomes kind of intrinsic, cellular deficiencies, or it's that they're so out of touch with what's going on with energy in their body and that they have zero metabolic flexibility that they have, God knows the last time that they burned fat.
Welcome to Personalized by Vitamin Lab, the show where we dive deep into the world of personalization in healthcare. I'm your host, Dr. David Dizer. Please remember that the following discussion is for educational purposes only, and it's not intended to diagnose or treat any disease. Speak with your healthcare practitioner first before integrating anything that you learned today. Join us as we explore the remarkable stories, breakthroughs, and possibilities that come with the pursuit of personalized healthcare. Welcome back to Personalized. I'm your host, Dr. David Dizer. Thanks so much for tuning in today. Today on the show, I had Dr. Heather Bartlett, family physician and metabolic disease expert. Dr. Bartlett and I had a great chat because we have very similar interests. If you're interested in helping patients reverse their chronic disease or prevent chronic disease onset, this episode is for you. Dr. Bartlett did her undergraduate in biology at Texas A&M and her medical degree at St. Matthew's University School of Medicine. She's the founder of Metabolic in Columbus, Ohio, where she practices what she calls a cell-up approach rather than a disease-down model. She offers individualized primary care and medical-grade biohacking to support optimal wellness for her patients. She has a special interest in cognitive performance, longevity, and weight loss. Please enjoy my conversation with Dr. Heather Bartlett. I'm here with Dr. Heather Bartlett. Hi, Dr. Bartlett. How are you today?
Awesome. How are you?
I'm doing well, thank you. Welcome to Personalized. Thanks so much for joining our show. We're very happy to have you.
Well, I appreciate it. It's an honor.
I had a good chance to speak with you in our little pre-chat and get a sense of what your practice is like and what you're interested in. And then I had a good read of your bio, and I'm quite inspired by your story. And so I'd love it if you could start us off by telling us, why did you get into personalized care? What inspired you to do this type of individualized medicine?
Great question. Short version is I didn't mean to. It became a necessity. And I think that more physicians and clinicians of all scopes, once you realize that when we look at studies of 100,000, 200,000, and we say these are great studies and we're really controlling for these studies, and then you take these things out into clinical practice and you apply that one study that without any other variables controlled, and you see it doesn't make impact, you start saying, what's going on? And that'll lead you down the path towards personalization, in my opinion. That was probably a more recent realization, to be honest with you, thinking about like the studies, but a need from a metabolic dysfunction perspective. Every single person is totally different where they are as far as their cellular needs, their deficiencies. They're totally different in their stress levels, whether they have families, whether they move, whether they exercise, whether they're over-exercising. If you're not taking all of these variables into consideration, I'm not sure that it's actually possible to help people into not just an elite level, but a basic fundamental health.
Absolutely. I agree. What type of things did you see? I read in your bio about in your family medicine residency, you kind of came across this idea, which is that there's widespread metabolic dysfunction and we need to do something a little different. What type of things were you seeing in clinical practice at that time?
Well, I was one of the few, and if not first residents, that there had been a patient, this popped into my head, who had profound morbid obesity. And I had become friends with a clinical psychologist who was doing his residency rotation hours with us, and we started talking. And she actually is probably my first patient that I actually thought, wow, this is really possible. And this was something that was possible within 6 to 8 months of residency, kind of a short window working with her. As you know, in residency, you inherit clients as the graduating residents move on. And she had lost somewhere around, I think, 70 or 80 pounds within about 6 months. And it was also getting to the root of understanding that trauma, also not often discussed in internal medicine, primary care spaces, because honestly, it's kind of a weird space to discuss it when you have a 15-minute at best visit, right?
Absolutely.
Of realizing, wait a minute, okay, so we've got trauma, we've got hormone stuff, we've got really bad advice. And I decided to give her really specific advice that was just trying something because she was tired and fed up. And honestly, the discussion about trauma didn't even come up initially. It was after a few visits of trust, right? And that she had never disclosed this to anybody before. Now you see that, and most people have some level of trauma, whether we realize it or not, right? Unfortunately. And these people have this burden that they're carrying, and they're not realizing that it's also creating all this kind of hormonal hell for them, right? And then we create these habits and these behaviors for coping mechanisms. So then you go back and you dip into your toolkit of what you got, which is only pharmacological agents, right? And that's where she had been in that space all along without making any success, right? So that was like a little tiptoe. Now, actually going back before family medicine, I would say thinking about wound care and in my general surgery internship, as I've progressed in my career, the more I questioned myself, what are we doing even with wound care? Why are we not, I think fundamentally we have to ask ourselves, if in medicine, of all types of medicine, what we are doing as clinicians is asking the body to do something at a very fundamental level. Will you please XYZ, heal, repair, build, whatever. But we've stopped to say, what if the cells can't do it? What are we putting a demand on them and they don't have what they need, right? So between thinking of fundamental surgery is just a surgery and a surgeon can do an excellent job and they can have a bad outcome, to a patient may not heal properly and it has nothing to do with the surgeon, right? To all the way to family medicine, which is, I've got nothing for you except for move more, eat less, problem solve something for yourself that I can't tell you exactly what to do. I think ultimately where we're looking at a lot of unrest, at least in the American healthcare system, is that if we're really being honest with ourselves, clinicians are dissatisfied, patients are dissatisfied, and it's because the question that's not actually said that we both want to get to is, we want to make you feel better. But in a disease-based model system, that's not what we're trained to do to help people feel better. It's to find the thing, right? And just make an intervention. But the patient, when they come in, they say, I don't feel well, will you do this testing? They too are not using the wording, I want to feel better, doc. Because they've never been trained that they're allowed to say that. They may use other words that they've been trained that could be collaborative to this, like a level of depression, a level of anxiety. Feel terrible, I've got no energy. But it's actually, I think there's a mismatch in understanding what we're able to do with traditional allopathic medicine and that conversation piece of, we want them to feel better, they want to feel better, but nobody's saying it. We don't know how to do that in a traditional space.
Understood. Where does that start now for you? How do you initiate the discussion with your patient base? Maybe they're coming to you because this is your vibe and this is the lane that you're in. But let's say that person walked into your practice now. What is the first type of assessment or even discussion that you would have?
So a couple of different things. So I have a pretty long intake questionnaire that if somebody's like, I don't know what to do, I'm totally overwhelmed, I don't know what testing, then it's like, hey, I got to know your backstory. I got to hear it all. And the thing is that when somebody is sitting across from a clinician, it feels kind of hard, right? And then you get a stress response and you don't remember things and all this other stuff. So, but if you can sit at home and you can really be honest and answer these things, that helps with the background, right? So why are they coming to me? How do I ascertain that? Basically now I've whittled this down to, what are your top 10, of 10 things, what are your top 3 goals? Could be energy, could be focus, cognitive, could be weight loss, could be concern about family history, dementia. What is it you're after? And then what are your top 3 challenges? And some of those are the same, right? And, or is it a satiety issue, that could be getting in the way. So allowing patients to quickly identify something that is not necessarily a disease that's creating this chaos in their life, I think is a very aiding thing to them to be able to put it into a different perspective, right? Because fundamentally, they're not saying, well, this rash is really bothersome on me, but it's more like everybody's staring at me in the grocery store, but it's not really bothering me, but I want it gone, right?
Sure.
So we have to think of things differently in that way. So allowing people to explain how their life is being impaired by whatever is going on, how they feel, I think is a big first step in door opening for a lot of people.
Oh, definitely. Definitely. And you can pick out clues right on this intake form. You can start to see things like lack of sleep, for example. Maybe the nutrition portion is not sufficient to your liking. Maybe you have some digestion questions on there. Is that typically how it goes for you? You review this before you see the person and you start the conversation that way?
Yeah. And so what I actually do is I go through and I mark this thing up. There may be places that I want more clarification. It's very checkable, so it can be fast, but they can offer as many details as they want. And I always find it really interesting the amount of detail that people offer that I don't force, which is useful. So it's going through, looking at this, and then saying, wait a minute, this is probably actually a beneficial thing, but they're doing this other thing that could be negating, right? The benefit of this. So there's some things just in here that are easy. We can try and see if we can get some movement before we do anything else. And more importantly, you're going to need to heed what I'm suggesting, because I can't help somebody who says the same thing, this isn't working for me, and they come back 3 months later and I say, well, did you try? Are you doing what I asked you to do? And the answer is no. And they feel the same. You can't be dissatisfied, right? You didn't do anything differently. Why would you expect a different outcome, right? Yes. So going through that, and then basically I create a map for them. So it's like, look, what's your goals, your timeline, and your budget. Let's be honest about everything. And let's create a plan over the next 13 months of what does this look like? Because isolated testing alone is not useful for most people. So we need to figure out, if you're going to do this, when are we going to recheck this to see for the outcome so we can move forward? So it is a curated map of, and then it's like, we can talk about some therapies, but I consider that there's 4 foundations that patients need to understand about their life, their lifestyle, nutrition, et cetera. So I call it movement, recovery, neurobehavioral, and nourishment. Okay. And everything kind of chunks into these foundations. And so any person, any client that's going to work with me needs to understand 99.9% of the work happens at home. It's not in my clinic, right? So I take a different slightly approach that, yes, there are amazing therapies that we can offer people that can kind of move people forward, but I never want to deceive anybody that exclusively doing some type of therapy is going to get you what you need. The foundations have to come first, 100%. Then we can augment that progress with therapies. But if you're not willing to do that, there's no guarantee. I can't make guarantees no matter what, but I can make even less of a potential guarantee if the foundations aren't heeded, right?
Definitely. Can you review those 4 foundational pillars again? Movement was the first.
Sure. Actually, nourishment, movement, recovery, neurobehavioral.
Nourishment, movement, recovery, and neurobehavioral. I love that. Can we start with nourishment? Tell me a little bit more about this pillar. Let's dive deep here. Are you doing nutrient assessments, for example? Do you make meal plans? What does your practice look like on the nutrition side?
Yeah. So maybe before jumping into the foundations, it's also helpful. Let me just say some of the testing that we offer.
Please.
So that's part of how the foundations actually grew out of the testing of like, wait a minute, it's not as simple as this test fits into only this box, right?
Right.
So we do body composition testing with an emphasis on visceral fat levels. We do resting metabolic rate testing, looking at what are your intervals of knowing really your cellular energy demand. Instead of thinking and training people to learn, it's not just about your movement. If we look up a giant biochemical chart, which most people do a walkthrough with me in our first consult, you got to understand the whole purpose of ATP is to make our cells go, which also help you move. But it is about cells first, right? So we do that. We do genetic testing with specific insights and that's another story, but basically there are people that I questioned in my old practice does this person have some type of genetic inability for utilizing fat as energy, different than somebody else? And I can get into that later. So genetic testing that's specific, that helps with macros from that perspective. Genetic testing that also helps from the perspective of how does somebody's body respond to cardio for a weight loss perspective, or to strength training from a weight loss perspective, if that's their focus. How are they likely to be in the mix of 3 different ranges for an increased VO2 with huge effort, right? If everybody wants to be Lance Armstrong and that it's just not genetically in them and he's a genetic abnormality, God bless him, that's amazing. But like, we can't all do that. So like some people may be coming to me for looking at endurance, right? Trail running, stuff like that. Well, we got to know our bodies are what they are, but we can honor it. We can help it as it can, but we can't force it to be something it's not. Right. So genetic testing from that perspective of very specific insights predominantly engaged from the nourishment perspective, and then the movement, knowing, there are marathoners, right, that I'm sure you've experienced, that they're pounding the pavement. They're absolutely putting a demand and a caloric need and all these things. And I feel like anybody who's kind of in the space understands the fact that you're getting this cortisol effect that's actually detrimental. But despite that, unfortunately, that specific movement of marathoners does not seem to understand that, right? So if somebody says, all I want to do is run, and we're looking at their genetic test that says, but your goals are this, and that's not going to get it done for you, you have to be willing to accept that, right? So I feel like I'm going to have to start throwing down the hammer harder in discussions of like, you can do what you like, or you can do what's going to work. Right. But you can't wish one into the other.
What you like or what's going to work. I love that.
I mean, because at the end of the day, this is not my passion is success for my clients.
Sure.
Right. And so if they're not paying me to lie to them, they're not paying me to give them lip service. I hope not. That's really discouraging if that's the case. So here we go. We got those genetic insights. Then we do where actually this clinic came to be was these cardiometabolic labs, really doing the deep dive on particle size, particle number, your lipoproteins, homocysteine. And that's actually what got me going towards, wait a minute, not everybody is the same in how it metabolizes, right? So there's that panel. We can go into more on this in a second if you want. But like we got that set. We're looking at fasting insulin, fasting C-peptide. And then you have your basic labs too, but like really that's kind of the heavy hitters that got me saying what's going on here. And interestingly, on a side note with that, why I cared about this so much was I never saw the type of cholesterol, like when you're looking at the stuff that makes plaque, I never saw that number change or improve when somebody took a statin. I saw the total number, correct. I saw the total number, right? LDL, total cholesterol, those would shift. But the actual particle size, particle number, small LDL, medium LDLs, those would not shift alone with the statin.
You didn't see volume of large LDL particles?
I mean, I have a little stack over here from my old clients, my old practice that tipped me into this practice that I was going to go shred them. And I was like, well, these are actually great case studies for people to quickly just see that I'm not just saying something where they can see the shift, name cut off and everything else, but still, because that's important. Because otherwise it's just hyperbole, right?
Yeah.
So that's what got me down that road. But okay, so we got those. And then telomere testing for anti-aging, knowing the end caps of your chromosomes. So if somebody's concerned from a longevity perspective, how you're doing. I've had a patient who's a 35-year-old gentleman who has a telomere age of a 60-year-old. That'll get your attention. And we're working towards that, improving that. The SpectraCell intracellular micronutrient test, which I think is the best, honestly. All of the insights that come from that. And then MTHFR mutation analysis. That's a big deal. I feel like that's something that's grossly been overlooked in the discussion of this pandemic that's happened and blood clot risk. The number of people that are walking around and they have no idea that they already had this risk. And there we go.
I would agree. My goodness, that's quite the list.
Hold on, let me see if there's anything I'm missing.
Anything else to add before I ask?
I know. I think that's everything. If there's something that comes back to me, I'll let you know.
Okay, sounds good. Can we start with your RMR, please? Because I do RMR in the practice here, which I love to do. Does your device report fat versus carb burning at rest?
It does not.
I'm interested. I think it varies day to day, but the company that we work with, they report the percentage fat burning during the resting test, and it can be quite discouraging for those marathoners when they see the paragraph that says, oh, your cellular health may be at risk here because your carb burning at rest is so incredibly high. And then, we're changing their training and we're reducing the impact and we're lowering that cortisol to try to get the fat burning up. We typically do it after 2 or 3 RMRs to make sure the pattern is that fat burning is unwell.
Sure.
But it's a difficult conversation.
Well, we are literally about to launch our coaching panel as well, and with a couple of different levels. And one of those is, I hear you about the RMR, but also it goes back to that study of how many people, I think that's a phenomenal RMR. Let me clarify that. But people not seeing in real time what they're really burning, right? Like somebody may be like, well, take your thing and be like, no, look, this isn't working for you as a marathoner. I promise you whatever your goals are, we got to shift it a little bit. And they're like, no, I'll be damned, I'm going to do it. And they just don't believe it because they think it's different when they're out there doing it, right? And I think that is actually the massive benefit between using a CGM and then also building and using the Lumen device, so people can really see in real time where are they at with that burning. So I agree with you.
Yeah.
That's phenomenal, though.
Yeah, that's interesting. I mean, the Lumen for a fasting level, I'm all for it. I think it could be interesting for them to use. Tell me a bit about your CGM usage. Are you doing like thinking about it postprandial, how every meal affects the person, and doing that kind of individualized approach with it?
Absolutely. And this is, again, like kind of an old tie-in back to general surgery, which was everybody has a different gut transit time, right? You learn that the hard way when you're waiting for somebody to pass gas after surgery, after they're metabolizing everything. So I fundamentally believe that if we're going to change things from a metabolic perspective in at least the United States, probably in Canada as well, we need to make it a normalization that CGMs are used on the regular.
Oh, I love it.
Anybody who's got a cholesterol problem, starting with cholesterol, and that's actually, so I was the odd duck that was prescribing CGMs back in 2016, 2017, before we had all these subscription things, because it was that cueing into there's some type of relationship to what's going on with their glucose and what's going on with their cholesterol pattern, because the statin wasn't hitting it. So I am a huge advocate, because you can tell a patient very strongly this is very likely what's going on, but until they actually see it with their own eyeballs, and that whole right before you eat and 2 hours after, that is a huge data set that is absolutely missed by the masses. You have no idea what somebody's gut transit time is. You don't know if they've got some inflammatory bowel that's going on where they are just poor absorption, so it's a very delayed glucose spike that they're going to get. But patients not being able to learn, not just every time you're getting this spike of blood sugar, glucose, you're getting this ride of insulin, and then you're getting this ride of cortisol. You're getting all this wonderful stuff that's not wonderful metabolically if you're already in a bad position. But if they can't see it with their own eyeballs, they're in absolute disbelief, and you're just a mean doctor. Right? You're just telling me to do something I don't want to do. Where this is giving autonomy to the patient to say, this is you. You get to choose what you want to do with this and how you feel. And also pay attention to how you feel. The number of patients who, even in medicine, as you know, we've been trained that if somebody's weak, lightheaded, whatever, they probably have low blood sugar, right? And we tune that into everybody. And the number of people that actually have an elevated blood sugar when they feel that way, and then they think, and they don't know it, I'll consume more because my blood sugar must be low. I mean, I think that this is a more common phenomenon than anybody will ever know. Now, you talk to the endocrinologist, nobody's going to say anything. They like how things are. They don't want to fight an insurance company, et cetera. All my patients, they pay cash for their CGMs. It's the only way for them to learn and know how their body is responding at this point in time. And they're going to be on a journey with me of how things are going. Right?
For sure. I'm totally into it. It's about $100 here in Canada for 2 weeks of use of the Freestyle Libre. Costco takes a bit of a loss, is my understanding. So they do it for about $90, which is pretty good. Not too bad, considering the insights that a person gets are just incredible. We're about to put one on my colleague here today. We've got a Dexcom in the office that we're gonna. Awesome. We encourage all the doctors to do it, right? So you get to experience your own consumption of glucose.
Absolutely. There's nothing more powerful than that, because to me, that is actually the first step in the journey for the patient.
Can we talk about the evaluation of it? It's probably where you were going, but even in metabolic dysfunction, I don't believe we're going for flat line during the day unless you have someone where you need to be keto, for example, because of other medical issues. What's your approach? How are you evaluating it, and how are you teaching positive change?
Sure. So I thought I would make my life easier just by asking my patients to go use whatever subscription that's out there at this point with their app, et cetera. But the problem is that the apps are so vague. They have to be, right? Because it's one medical director for a company. They're not looking at these things. So it's just AI generated, which I understand. But at the end of the day, if you're trying to get a patient to appreciate what's going on with them metabolically and how their body is interacting with energy, that's how I put it. Energy just in general, whether it's glucose, fat, protein, let's just call it energy. They have to know what they've been doing. So in the process of working with patients, that's when I realized, hey, I need to actually curate my own journal for people. Because not only is it a journal to know what they're doing, but also it's an easy feedback to them that when they look at this is their cues of, these are all the different ways that they should be biohacking themselves to get their glucose under control. And if they are not utilizing one of these sections, one of these options, and they're just leaving one out because they want to, and they're not getting to their goals, that's on them. That's on them.
Mm-hmm.
So they have the option. I tell patients, like, I walk them through it. Hey, part of it is I just want you to see. You need to see how it's moving, how it pings. You need to make your range in tight initially. That was a mistake I made, letting them have an open range so they wouldn't get pings and dings all night. Big mistake, because everybody said, look how in range I am. And it's like swinging up to 170, 180, 190. Nope, no more. Mm-hmm. So now you're between 70 to 120, and now you see how it's shifting. So number one, it's know where your body is doing with your current lifestyle. No changes. No changes for 1 to 2 weeks. You absolutely need to see the pattern of what's happening, right? Then after that, we can discuss if I've already told them or coming up. Usually I try to wait until we get their full labs, and their labs usually take about 30 days to get everything back, unfortunately. Then to say, okay, what have we learned? In the meantime, if they want to have a CGM review session with me, we can do that. We can look at it. They can take screenshots, upload it into the journal, have them talk through what's going on with that. I've teetered with the idea of using some other kind of add-in tech for monitoring stuff. I put a pin in it for the moment because honestly, people get overwhelmed, and what we really need to focus on is knowing what they've been doing so it's every week, at the end of the week, they complete this journal. They can use it for their own reflection. They don't have to show it to me, or they can say, yeah, I scheduled an appointment with Dr. Bartlett and we're going to review this on this day. And as these things come in, I look and I know if I need to do a review or not. But it is part of the journey of them understanding what has to change, right? If somebody is going for a metabolic dysfunction purpose, so pick it, if we're talking about cholesterol, chronic fatigue with mitochondrial downregulation, if we're talking about blood sugar, we're talking about weight loss, all these things, then yes, actually I am getting them to figure out how we can get those spikes that are not related to exercise, not related to the Samagi effect, lower consistently, because it's going to kick somebody out of that metabolic flexibility of being able to utilize ketones as they need to. And part of my journey was realizing that not everybody has, going back to that genetic testing, an equal groundwork on the utilization of fat for energy. So step one is somebody can try doing keto, nutritional ketosis, which I'm a fan of, not dirty keto. It's part of my history of the journey of working with people. But we do have to figure out how to control that. And most of the time, it's not just them walking around and wiggling, it's what's coming in, right? Mm-hmm. And that is the big thing that we have to understand as clinicians, and not be shaming or blaming, but like, hey, this is not vibing for your body right now. Mm-hmm. The most hard question to get is, well, when am I going to get to change back, doc? Like, is this going to be forever? And I always like to say, tell me, do you know the answer to that? Because I don't, and I'm not going to guarantee it. But I'm betting this is not, you got here, you arrived at where we're at because something's not been working for you. I would love if you could go back to your old ways and it's like seamless. But if it's not, the whole thing is about honoring our bodies. We don't honor it, we don't get the results.
Vitamin Lab revolutionizes personalized supplements, empowering health practitioners to create tailored supplement formulations that address each patient's unique needs. Bring personalized health to your practice and choose from over 200 professional-grade ingredients to create vitamin formulas that improve patient adherence and result in tangible outcomes. All ingredients are sourced from the world's most trusted suppliers, and Vitamin Lab provides hands-on support to help you formulate and launch personalization to your patients. Say hello to a new era of personalized supplement solutions. Go to getvitaminlab.com/personalized to save $100 off your first formula.
Oh, I like that. That's powerful. That's really good. Oh, I'm totally into this. I love your approach. I love that educational approach initially with the journaling. The journaling is not something I'm doing. I'm relying on this email feedback. What did you think the first week? And then here's my reply, but it's costing me too much time. So having something in the EHR, I think, as a journal template would be very valuable for me to make it seamless.
Yeah, I mean, the thing is that you also need to standardize the process for the patients, right? Because if you're off chasing one thing and you don't know if anything else has moved, I mean, they could be doing exactly what you've asked them to do, that one thing, and this other thing is absolutely causing havoc. Mm-hmm. So there is virtue in a standardization of process, not necessarily to the patient, but in the process so that you can see how things are going for them, in my opinion.
Definitely. Yeah, I would agree with that. I had the really cool fortune of learning about this from an MD who worked at Diabetes BC. Let me spend a day with him, and obviously just working with diabetics all day long. This is what they were doing. This was like 5 years ago.
Mm-hmm.
All day long, people were coming in, with an insulin pump and wearing CGM at the same time. And he just had a little sticky note, and he was saying, at this time of the day, look, this isn't so great. What did you eat? Here's how I would change that meal. And he was just handing a sticky note. And I thought, oh, wow, okay, this is cool. This is a conventional system doing this here. I can do this in my own practice. And we just started doing it like right away. It's been so fun.
Yeah, absolutely. Absolutely. Part of the impetus for me finally sticking my nose out and saying enough of full-scale primary care and this is my passion was actually because of Dr. Sarah Hallberg. I don't know if you're familiar with her.
I'm not familiar, no.
She gave a powerful TEDx talk in Indiana, I think at Purdue, in 2015. And basically, she was one of the first, I don't even remember how I found this TED talk, but of showing the power of insulin control in her diabetic panel, and basically also being wise and aware to flying in the face of current medical recommendations, which were not helping her clients. And so she said, well, let's try this, right? And so, and she was one of the founding physicians of Virta. They added her in as an expert, and they were the ones that forced the American Diabetic Association to put low carbohydrate as an option for therapy in the United States. They absolutely resisted it. And they had to do their own studies, massive studies, to show the benefit of it, which is nutty. Now, in the United States, on average, 17 years for the standard of care of medicine to change. I am trying to educate the public and patients about that, because if people say, well, my insurance doesn't want to pay for it right now, or my doctor doesn't think this, or they say it's not in the guidelines, I hear you. But also, if you're in a place where you're trying to have longevity on your side, and you're just waiting for everybody to greenlight it, you also have to know that there are forces that will never want to greenlight this. So meanwhile, if you've got metabolic dysregulation, you're building up plaque, et cetera, nobody can take that away from you. That's going to be there. We can stop the process potentially if we get lucky.
Difficult to reverse.
Right. But don't hold your hat expecting the standard to be. There's a reason why mundane and mediocre should not be exceptional in medicine. It should not be the standard. I mean, you and I both know the forces that are in play, and we don't need to go into that. But at the end of the day, the public needs to be aware that they need to be their own advocate.
Definitely. Sounds like you're a good communicator of that point.
I try. I don't know.
It's easy for me.
I think you and I agree.
We agree. Yeah, I'm in a scenario. I'm a naturopathic physician, so people come to me knowing that we've got a little bit of a different way of being and way of practicing. About 90% of people are coming here now thinking about it from a primary care sense. So it's really cool here.
That's awesome.
But you've got an excellent way of communicating it, and I really resonate with how you're describing it. I would love to take our conversation into SNP evaluation, because it's not something that I have a lot of knowledge around. I use an assessment tool that kind of shows some clinically relevant SNPs and SNPs with human research.
Well, I will tell you. So I utilize genetic direction. I have no problem telling you that.
Genetic direction. Yeah, sure.
And I looked high and low when I was trying to find a resource that really dialed in to these macros and these exercise discussions, right?
Right.
And it is not, a lot of patients will come in and say, well, I had Ancestry or 23andMe, or I did this one other thing. And when you look at the other offerings that are out there, they are abysmal in how they're really putting this together. So many of these, when we're looking at even like the cardio for weight loss, for example, there is a number of genes that they're taking, and SNPs and alleles that they are looking at in unison. It is not a one-off thing. So that is part of the power to this. When you look at something in isolation, when I look at these other reports, it's like this one little thing, it says, this is not useful to me, not as powerful. And so that is why I utilize genetic direction.
Okay, sure. Okay, so it puts it together as sort of like a package that includes 3 different kind of categories of expression.
Yes. So as things are relevant that they could be making an impact together or against, it is pulling all of this to make the recommendation of where somebody lands in their genetic profile. So, they, on the reports, for example, is to say it's below average, average, above average, just making something simpler. Some of them are like average, below average, lower average, right? So it's a little bit different on their scale where somebody lands. But it's important in seeing the relationship to that and it isn't necessarily, I learned that I had to make my own report. And as in process, thinking about your email journey with CGMs of, wait a minute, how do I create a tool for patients to be able to reflect back on all these complicated labs that they can know the meaning, and it's not just me in this lab and over 200 pages of reports that they're never going to look at again, right? And part of that was with these, ranges saying optimal, average, suboptimal, giving people a scale of where are they falling on this rather than just average, below average, whatever. What does this mean? And I think that that's a helpful thing, because if you're just looking at where you land and you don't know where you could have been genetically, it doesn't give you perspective. Can't change it. It's who you are. That is a healthy perspective, but you might as well know, like, hey, husbands, wives, partners, we're doing the same thing. How many times do you have this discussion, David? That it's working for them, but it's not working for me. I'm hoping you have two different sets of genes or something interesting is going on, right?
You're hoping.
Yeah, so we have to honor that. Yeah. But and really people, and that is something that actually has to be said over and over and over. Right. That's like, you're different.
You're different.
You're living in the same house, but you are two different beings.
Definitely. Let's narrow that focus. Let's narrow the focus into free fatty acid metabolism.
Okay.
Tell me a little bit about your experience with the evaluation of these SNPs and genetic presentations, and then your approach to optimization of free fatty acid metabolism.
So first of all, it's getting the roadmap for the person, right? One. So we need to know where they land genetically, macros, et cetera. We need to know what they need to be doing for exercise. Past that, it's getting people to, on a very basic fundamental level, and this is something that probably in the last 4 months, I finally started breaking down for people when I say, look, do you understand how fat goes away or how you use fat? Like, just tell me. This isn't just no judgment, just whatever. And most people really don't have an idea. And this is where I have to present the case that I'm about to become very unpopular, right? Because the first thing that people need to understand, right, in the step of lipolysis is the signaling to release if somebody is going towards a weight loss journey, right? Which a lot of people, whether they look like it or they have visceral fat that's being well hidden underneath the strong abdomen, is happening, or fatty liver even, that the signal is probably not happening. And that's part of the roadmap, right? So what are the things that impair the signal, and what is the hardest discussion around that for most people? It's alcohol. So they can be doing all of these things right, quote, exercise, eating the right thing, et cetera, but they're still playing with alcohol. And when people say, well, if alcohol, I cut it back and I lost weight or I had this benefit, and it's like there's a certain caloric energy reduction that you will get some benefit, but then it's going to plateau. And then you have to understand that it will literally kill the first signal for that triacylglycerol release from adipocytes, fat cells, to go into the bloodstream to get to that end organ that has the demand to utilize that for energy, right? So this is what I'm going to tell you. I'm going to tell you this is how I explain it to patients, so hopefully it helps another clinician. So number one, if that's going on, we're done. All your other effort, your supplements downstream, everything else, you're going to be paddling up the river. Maybe you get some benefit, maybe you don't. Probably not going to see the benefit on your cardiometabolic labs. That's through clinical experience, okay? But besides that killer there, it's everything else. If their glucose is totally riding out of control, they're never going to get that signal for that release. So most people, I think, at least in America, are fighting against getting the first signal to even get that triacylglycerol release from the fat cell into the bloodstream. Okay, so great. So we do that.
You mean I can't have my wine every night? Come on, Dr. Bartlett.
I know, I'm buzzkill, literally.
Totally.
But that's an important thing. And I tell people, like, look, you're not paying. There's a reason why nutritionists, unfortunately, will tell you just cut back or have less, because you don't want to hear the truth. And maybe they don't actually understand this. And I'm not ditching on anybody here. But like, you have to honor biochemistry. Have to. So let's say we get that signal. Praise be to He, because that is a big deal. Now, how can we get that screwed up, that this triacylglycerol that has now been released into the bloodstream, and we're trying to get it to this target organ that needs to use it for energy? Where do we screw that up? Well, we can screw that up because the signal was there. And then we interrupted the signal. How do we do it? We eat something. There's not the demand anymore. What happens to that triacylglycerol? It goes into a new fat deposit. Just shunts right into someplace else. Ba-zoom, right? So there we got that. So let's say, okay, we get it to that end, the end organ that needs it. What is going on at the cellular level of the demand, the ability to get that into the cell, right? So let's say we got to get that right, get it in. Great. What happens now? We got to get it across the cytoplasm of that cell. What can go wrong there? As you know, tons of intracellular deficiencies will screw everything up. Okay. Let's say that's okay. Let's say we get it to the mitochondria where it's going to actually be processed. Well, we got to get it into the membranes, right? Okay, there's things that can go wrong there. Now what happens if we have dysfunctional mitochondria? Like they're down-regulated from leptin resistance, they're poor quality, you name it. Okay, well, that's not great. But then also, what if the mitochondria don't have the substrates that they need? So let's say you get it all the way dang there, and you've got floundering mitochondria that are supposed to turn this into a fatty acid into CO2, water, and ATP, but it can't do it well. So there's all these different places where something can go wrong in this journey that we grossly oversimplify in medicine and say, move more, eat less. And it's far more complicated than that.
It's far more complicated.
But there are solutions to it. I mean, that's the beauty of Vitamin Lab.
That's the beauty. Okay, sure.
Yeah,
Vitamin Lab, excellent. As a clinician looking to follow that sort of stepwise process for the person in front of them, they're looking for clues, right? They're looking for clues. We started with the conversation with the genetic approach, which I can see the value here because you're trying to find kind of the low-hanging fruit for each step, which genetically that makes sense. Am I right?
Yes, to me it does. Go into the genetic test just briefly. Like there was a gentleman who, let me give you the background quickly on this. Sure. So after going to a conference at Ohio State University in 2016, thinking about Dr. Sarah Hallberg and following down that range of Dr. Jason Fung, the nephrologist, University of Toronto, who's huge intermittent fasting, thinking all these things of also, why is it that there are patients who do intermittent fasting, they don't have success? Why are there people that try doing nutritional ketosis and they don't have success? Like the question is, why are some of these things failing for people instead of saying they're not doing it right? And there might be a potential of that, but let's give them the benefit of the doubt that they actually are doing it right. But there's something that's getting in the way. And that something could be intrinsic, genetic, or it could be something exogenous that becomes kind of intrinsic, cellular deficiencies. Or it's that they're so out of touch with what's going on with energy in their body and that they have zero metabolic flexibility that they have, God knows the last time that they burned fat or were able to get into some level of ketosis, if we're being honest. And so I started working with patients very, very deeply with that. I mean, we're talking with a tape measure, a clothing measure, going around their greater trochanter, around their hips, around their umbilicus, measuring it in centimeters, and trying to do assist them through nutritional ketosis the best I could, but also getting the friction point of how are we doing that. That's what I realized with people checking blood ketone levels, that, wait a minute, why are these people not getting into ketosis? Step one, go back to glucose pattern. So all these people that are racing and trying to do nutritional ketosis and they're not having success, they're not having weight loss, et cetera, there's a glucose problem. And they've got to understand that first. Then, once you know that, and the Keto Mojo, they were wise enough that they came up with the glucose ketone index, GKI, that showed that it didn't matter if you just had blood ketones. There's a relationship in the depth of ketosis that needs to happen to get benefit, right? So, I mean, I guess if he was in this level of carrying on a clinical level, Dom D'Agostino out of Florida, he could probably share this very quickly to everybody, right, with his research with that. So that's how I actually got here, was how come half these patients that are really committed are getting tremendous success, right? They feel better, they're losing weight. The other half aren't, they're doing it. And then you got this weird little mix match in between where they seem to be doing well, but their cholesterol panel seems to be going a little unusual. Now, and also, what are the studies regarding that? Like, what are the studies looking at a tremendous large-scale weight loss for somebody and what happens to their lipid panel? And there definitely aren't those studies that talk about what happens in an advanced lipid panel. They're all in the basic cholesterol panel, right? So we've got this big blind spot where if something is going on, somebody's feeling better, they're losing weight, they have more energy. And if I wanted to panic, I would have said, well, everything's going wrong because look at your cholesterol panel, right? We don't know when that's, and I forced many of them forward, like encouraged them, like, let's keep going, because people flip sometimes at the last minute as they get closer to their ideal BMI. We don't know when people's cholesterol patterns are going to flip. Some of them will change very quickly. Some of it takes a dang nab long time. So this is where, when we're looking about the studies of, 3 months, you get a lifestyle intervention, do this thing, and then, sorry, if things aren't better, we're going to put you on a statin. I'm not sure. I don't know that we're holding enough water in these discussions to really know how this is going to play out long term for people.
Completely agree. Visceral fat can take a long time to metabolize. And, this is, to your point, like, this is how I got into this as well. I was doing low carb diets for people. I was doing low carb intermittent fasting, and a certain percentage of them weren't having success. So we started doing resting metabolism tests and doing nutritional deficits, guaranteed nutritional deficits. Turns out they were following what we were suggesting. They were eating in a deficit, but the metabolism was declining. It was getting worse, and we were just relying on glycogen stores, and RMR was declining over time. And, we're experiencing muscle loss. So then you say, okay, well, we need to optimize for fat burning. And you've got an excellent step-by-step approach, I think, that physicians can take seriously. And there's tons and tons of case studies I'm sure you can share on that point. But we have to move forward into nutritional assessments. So we have this blood sugar control, genetic evaluation and assessment and approach. And then we think about maybe the genes are influencing nutrient levels or nutrient utilization. What's your thoughts around this?
Yeah, I mean, I have learned the hard way to never guess what's going to show up on somebody's intracellular test at this point. Things that I think, yeah, probably, no. I've also learned not to play with the idea of what may reveal itself on an MTHFR mutation analysis too. And I also learned that my genetic test MTHFR potential testing is not nearly as powerful as Spectre cells. So I don't lean on that when we're looking at methylation ability from the genetic test. I lean on what's the best test for that. Ultimately, what I've found is, here's the crux. Going back to that first thing we talked about with people, the doctor wants people to feel better, the patient wants to feel better, but nobody knows how to verbalize this, and there's not a methodology otherwise. The patients who take it seriously, okay, and it's hard to believe that there are patients that would not absolutely heed this, considering the investment that they've made in their health. But the patients that take this seriously, and we go through and we build out what they need from an intracellular perspective, borderline functional, plus let's build in some other things from senolytics, et cetera. The first thing that comes out of their mouth is, I feel better. Okay. And I never lead with that. I never say, how do you feel? I say, how's it going? It could be anything we're talking about. I don't want to know how you, I want to hear it all. So let's not lean with that, right? With the genetic testing, for example, I grab all 4 panels. I've got 4 different panels, and one of the panels is a nutrient panel. And before I started learning about the power of the need of addressing what's going on inside the cell, I would lean on that test from this perspective of, it's telling us what the genetic tendencies are in somebody for like vitamin A. What alleles do they have? So what if you consume it? Can the body get it to the state that it needs so it's useful to it, right? And so the power between the intracellular and that genetic test, for example, plus vitamin lab is, okay, if somebody comes back with something on the intracellular that is a borderline or a functional deficiency, and then we go over and we look at the genetic report, looking at their genetic tendencies. And if 2 of those things are crossing over, that's a pretty good hint that this is probably a lifelong thing that we need to stay on top of with the best quality supplement that we can.
Right.
Hint, hint, right? So genetic tendencies is training people. Genetic tendency, things can turn on, things can turn off, epigenetics. But like, this is what we got. This is what we're working with, and this is how we can adjust things, right? So not giving the body what it needs at a fundamental level is the biggest screw up I think we're making in medicine at this point.
I can completely agree with that.
When we're talking about wound healing, right? You think about all the people that are in skilled nursing home facilities right now. We're thinking about all of these people who are our age. We're pretty youthful. Let's go with that. We're pretty youthful. But we're tipping towards, right? And this is the age where we start taking the risk for dementia seriously. Not when we start having symptoms, as you know, right? If this is a 10 to 20 year process before we start exhibiting symptoms that this has been in play. When do we start actually educating people that they absolutely have to take action? Andrew Huberman, right? Huberman Lab.
Of course.
Okay, love him. And my epiphany about him was what I appreciate the most is that while he gives everybody access to these free protocols, the one thing that is somewhat subversive that he never says out loud that people buy into, hopefully, is it takes effort. The protocols themselves, even though they're free, take effort. So you have to make a level of commitment and understanding that health is not passive.
Definitely.
It absolutely is not passive.
The biggest conversation I typically have around that is following a fasting insulin test. If we see a HOMA-IR that's elevated and we're thinking about their body composition and the muscle being low, we're spending a lot of time talking about optimizing for muscle mass. What does hypertrophy training look like? And what's the timeline for muscle development? Aside from the nutritional conversation, of course. Tell me about your use of fasting insulin and C-peptide. Are you reporting HOMA-IR, and how do you evaluate these labs?
So, So insulin resistance is the devil here, that everybody says, right? Because it's the precursor. And you and I, we talked about this very briefly. And what I had to try to figure out is why is it that there's individuals who do well when they change their nutrition, they use a CGM, maybe they even just go on metformin, right? There's some type of blood sugar regulation temporarily. And they get some benefit where they start to lose weight and then they plateau. And they keep doing the same thing that was giving them benefit and it stops. And maybe they go down in their calories like you were suggesting. But ultimately there's this plateau. And if you're checking the labs over every 3 months, you start seeing, well, there was this benefit of somebody's A1C, because I'm talking in traditional, most people are not checking fasting insulin and fasting C-peptide. So we're just looking at A1C. And all of a sudden now the A1C is halted and it's actually starting to bump back up. The cholesterol panel might be getting weird and they're starting to gain weight again. So this is my hypothesis of what we're missing in medicine very simplistically is that insulin resistance is not necessarily the devil. The pre-devil to that is extreme insulin sensitivity. That is part of where this roadmap that I've tried developing with patients is for them to understand how, if you're thinking about a cell, a revolving door, if you will, with insulin and glucose, extreme insulin sensitivity is just hoarding all of this energy into the cells. So, and we'll say for the purpose of metabolic dysregulation, we're talking about fat cells. So it's going in. And it's going in at a rate that is incredible, right? So how do we have, and I'm sure you've had this experience, and patients who are morbidly obese, youthful, beautiful cholesterol panels, even advanced panels. Well,
Definitely.
That's odd, right? And we've got a number of people who are touting this and et cetera. And their youth is holding off. Their cells are willing to accept this energy, and there's going to be a tipping point. Everybody's got a tipping point where, and this is the thing that we can't predict, and maybe we'll get that good in medicine someday that we can, where the cells say enough. That's when insulin resistance kicks in. So here you have this little revolving door of hell for people that all of a sudden we've stopped the revolving door has slammed shut, glucose can't go in, so glucose has to stay in the bloodstream, so now it's climbing up. Now we're looking at prediabetes, we're looking at diabetes, cholesterol panels go aberrant, but maybe the weight may plateau for a second. It's not enough to keep playing around the revolving door, is what I've learned the hard way. You can't keep doing insulin resistant to insulin sensitivity and saying that, your cells are insulin sensitive now, everything's okay. So A1C drops, weight goes up, because it's going into the cell, it's going someplace. We're just not thinking this through. So my goal for my clients is we're moving towards a space of metabolic flexibility. We're getting away from the revolving door. We're learning all these different attributes that could be contributing to why this door keeps happening. And we want to get to a clean space where what's coming in is being utilized pretty readily on the regular.
Right.
It's not having this potential. It's the same thing of like, why does one person, as one of my patients taught me the term skinny fat, I know I look skinny, doc, but you're not going to like my cholesterol panel. And dang if he wasn't right. Okay. And why do some people, they hoard this energy into cholesterol panels before it goes into their actual body fat? Don't know that yet. But both of those pathways, whether it's somebody with an obesity issue versus somebody who has just bad cholesterol and or with the other person with cholesterol, now, ultimately, the resolution happens with this metabolic flexibility. It improves with that. So this is actually just about getting the body to function in a way that we used to 10, 20,000 years ago, right? Are you familiar with Dr. Robert Johnson out of Colorado, University of Colorado?
I'm not.
So he was somebody that I had stumbled on a long time ago, which also got me thinking further, which is his research was looking at insulin resistance, and he was calorically controlling. It was he saw something abnormal with a fructose solution, okay, in his studies. That metabolic dysregulation was worse. Metabolic syndrome in these mice, everything was worse. And so he was like, well, that's weird. Well, let's calorically control energy-wise. So it's not a gram to a gram because of fructose and sucrose plus glucose. So we'll make it literally calorically equal, these solutions, and see what happens. Because the energy is the same. It shouldn't do anything different. And the outcomes from a metabolic dysregulation perspective were far worse with the fructose solution.
Right.
Okay. Well, not everything is equal, right? So we've got a lot of people that say do juice cleanses. When you're, and we understand the absorption, and it's a simple sugar and it's faster absorption, all these other things. But fructose, going back to our 10 to 20,000 years ago, we had fructose a season when it was in season, and it worked well for us. We would increase our body fat because we would be going into a cold season where we would not have these stores. It was a physiological adaptation that worked well for us, but it's not working for us now. It's killing us, right? So the revolving door is everybody's problem. And we've oversimplified that insulin resistance is the only problem for people, the big precursor, when it's extreme insulin sensitivity, high amounts of energy, insulin willing to go in. That's actually it. Because you fix the insulin resistance, that happens again. That's not a good enough solution.
Sure.
Does that make sense?
Sure.
I know it's kind of complicated. It's hard to without like doing a diagram sometimes.
The diagram was in my mind because you communicated it so well.
Okay.
No, I totally get it. And it kind of pulls us full circle, right? In order to optimize for metabolic function, we need to be thinking about genetics and nutrient stores and lifestyle attributes and personal and assessing via personalized responses to the typical foods that are in their diet, how they're eating day to day. I love it. I feel like we had an opportunity to do Dr. Bartlett's pillar number 1, nourishment, which brings us to the finale of, I would have to say, part 1 with Dr. Bartlett. Thank you so much for explaining your approach to this nourishment pillar. I'm all about it. Love it so much. How can patients and physicians, integrative physicians and naturopaths connect with you online? Where can they find you?
Sure. Honestly, just reach out on the contact us form if you want to on my website, metabolab.clinic. So like metabolism lab, metabolab.clinic.
Great name, by the way. Such a great name.
Thanks. The one thing I always have to run into, people think I'm just a lab, and I'm like, no, it's, roadmap. I'm trying to get you your roadmap for your body. But just reach out that way, easy peasy. Hopefully in the future, I'll put some more stuff out on YouTube. It's kind of more specific to this. I'll be honest with you. I just figured most clinicians probably knew this, and I was the last one to the dance. And so I'm happy to share and educate because we've got a huge metabolic burden that in the United States, Medicare can't handle it and can't pay for it. And, the last thing I'll say real quickly about that is it's super interesting when people decide that they should not invest in their health. And going back to kind of the standard of care and how long it takes for things to change, you absolutely have to invest in your health, however you want to, but you have to make that decision because nobody's going to invest in your health for you. Not our government, not a health insurance. It's not going to do it. So you really have to be the leader of your own pack for that. Patients in my old practice, my primary care, this is what I found super interesting. They could have a bad knee for 5 to 10 years, right? And they wasted younger 5 to 10 years of their life in pain and everything else because they just wanted Medicare to pay for it later. So they lost 10 years potentially of quality life because they wanted somebody else to invest in their health rather than them invest in their health. I know that's an extreme thing, but the truth is time is the only non-renewable resource. Some level, you got to think about health the same way. And especially when we're talking about these chronic disease processes, when we're talking about dementia, it takes all these years, and we're talking about plaque. It's the time to invest is now. And I'm very happy to be recommending my patients to be utilizing Vitamin Lab, to be honest with you, because there's so many things that need to be done for people to re-engineer their health that simplifying in that category is a huge win for them.
Wholeheartedly agree. I'm all about it. I think you expressed it incredibly well. You've inspired me to think about my own labs. I had a chat with a 30-year-old this morning, And he was sitting there and saying, well, what can we do? What else could we do? Well, there's a lot of things that we can be doing. There's a lot of things we can be assessing and thinking about to prevent the onset of disease over the next 20, 30 years.
Mm-hmm. It's investment, and like Huberman accidentally sneakily does it, and action.
Sure. Thanks so much, Dr. Bartlett. I really appreciate your time. I thought that your way of communicating all the concepts we talked about today were inspiring. I think clinicians will get a lot out of this, so thank you so much.
Happy to do it. It's an honor.
Talk again soon.
Sounds great.
Bye.
Thanks for joining us for today's discussion. What about today's podcast resonated with you? Be sure to tag at Dr. David Dizer and at Get Vitamin Lab. If you're learning from and enjoying this podcast, please let us know by subscribing to our YouTube channel and follow the show on Spotify and Apple. And don't forget to leave us a review. It's the best way to support our podcast, and it helps others find us. To learn more or book a demo to explore what personalization could do for your practice, please go to www.getvitaminlab.com/personalized.